talking about the health implications of obstructive sleep apnea in West Virginia. My objectives today, I'm going to review some of the pathophysiology of obstructive sleep apnea. And the reason I do that is I do think it helps people understand why it sort of impacts these other health conditions I'm going to discuss. And then I want to discuss the current management recommendations for obstructive sleep apnea. And, you know, a lot of what we do now for the management is outside of a sleep lab. And, you know, I think particularly in our state, primary care providers get more and more kind of saddled with doing the management of obstructive sleep apnea for, you know, a variety of reasons. And then finally, I want to consider why it might be, you know, really important in our local Appalachian population. So when we think about obstructive sleep apnea, you know, on a sort of basic level, it's repetitive airway closure during sleep. But there's really more to it than that. And when you talk about, I think people sometimes get confused with obstructive sleep apnea and sleep disordered breathing. So sleep disordered breathing is sort of a broad diagnosis with, you know, kind of different subsets of types of patients that you see. So you can have folks with obesity hypoventilation syndrome, which is really a problem in our state. And, you know, that's when people tend to retain CO2 for no other reason than just being overweight. And there's definitely some significant health consequences associated with obesity hypoventilation syndrome, including pretty bad pulmonary hypertension. You know, we see a lot of these patients in our ICU. I feel like I intubate at least one or two of these folks a week. And many times, you know, they'll end up trached on, you know, chronic vents, at least for a while. So a lot of healthcare costs associated with obesity hypoventilation syndrome. You can have complex apnea, including Cheyne-Stokes respirations, where you're not really getting that repetitive closure of the airway during sleep, but it's more of a central process where, you know, the brain isn't sending those signals out to, you know, tell the body to breathe. Then we have obstructive sleep apnea. Again, that's where we have these repetitive airway closures during sleep that lead to hypoxemia and big swings in thoracic pressure. And we grade the severity based on the number of respiratory events that we document per hour of sleep in the moderate, severe, and mild. And that's important because it does have, you know, health implications. In the moderate range and certainly the severe range, you really start seeing the health consequences of obstructive sleep apnea. Where in the mild range, you know, we typically wouldn't treat someone aggressively unless they're very symptomatic. And as I'll show you, there's a very good correlation between apnea severity and health outcomes. There's not a very good correlation between apnea severity and symptoms, which is sort of interesting. So what happens during obstructive sleep apnea? Well, typically there's, you know, these things that promote airway patency versus, you know, different processes that promote airway collapse. So when we sort of breathe in, you know, or we use negative pressure to breathe in, so our diaphragm falls down, our lungs are sort of pulled out, and we kind of suck air into our lungs, right? And that gives negative pressure in the airway on inspiration. So, you know, in health, we have strong pharyngeal dilators, with the most important being the genioglossus or the tongue. And then as, you know, you have good healthy lungs, there's actually tension put along the upper airway when the lungs expand to sort of maintain patency. Typically what happens in obstructive sleep apnea is many times there's some anatomic predisposition that leads to airway narrowing. And then the other thing that really drives sleep apnea and promotes airway collapse is, you know, obesity. And what we see in sort of our local Caucasian Appalachian population is, you know, the lateral fat pads of the neck really become enlarged, and that, you know, puts pressure on the airway, leading to airway collapse. And this risk is mediated by, you know, there's some genetics component really of risk factors that cause sleep apnea, such as obesity, craniofacial structure, respiratory control, and then obviously the environment can play a role as well. So what happens in sleep apnea? So as I mentioned, you have this airway collapse, you have decreases in airflow. And then the way the body compensates is as the flow decreases, you start breathing harder and harder to try and break that apneic spell. And that's associated with oxygen desaturations, arousals, and big swings in thoracic pressure that puts tension along the walls of your thoracic organs. And all of this leads to pretty big increases in oxidative stress and sympathetic nervous system activation, with the consequence of heart failure. There's very strong evidence that sleep apnea is a risk factor for stroke, good evidence of causing increases in blood pressure, questionable but likely myocardial disease, particularly middle of the night. Usually you're protected in the middle of the night from having myocardial infarctions, but folks with sleep apnea actually are at increased risk. And then arrhythmias. And our electrophysiologists, before they even consider an ablation for a patient with atrial fibrillation, they send them to the sleep center for an evaluation, because sleep apnea is such a huge driver of atrial fibrillation. So what are the outcomes of obstructive sleep apnea? These are the kind of two biggest cohorts that we have. The Wisconsin cohort has about 1,400 public employee patients. Essentially what they did was say, hey, you guys want to do a sleep study? They did a sleep study. They got a letter in the mail saying these are your results and you can do with it what you would. So didn't necessarily get treated. As you can see here, you start seeing a little uptick in mortality in that moderate range, and you can see in the severe range, these patients really did poorly. On the right here, this is from the Sleep Heart Health Study, another big cohort. I think it was about 6,000 some patients. And again, you really started seeing upticks in mortality with that moderate degree of obstructive sleep apnea, and certainly with severe obstructive sleep apnea. So I think most people know that sleep apnea is bad and it can lead to adverse health outcomes, but I think where we struggle sometimes is, who should be screened, what testing should be offered or should be ordered, what treatment should be offered, and then what type of treatment should be offered. So I think everyone would knock this kind of guy out of the park, very morbidly obese, large neck. You have some evidence of lower extremity edema and chronic stasis changes. Sleep apnea is a big risk factor for right heart failure. So I'm sure this guy kind of retains a lot of fluid. But if you just look at sort of the general population and looking for like overweight guys who snore like a freight train, we miss a lot of the patients who actually have obstructive sleep apnea. And it's sort of interesting as we get older, some of the classic findings are very insensitive for identifying obstructive sleep apnea. We've actually done some work in the CHF population, and a lot of the risk factors like the stop bang questionnaire that kind of help us risk stratify people really don't hold up in these older patients with heart failure. My suspicion is COPD too. We're starting to look at that as well, but our group's certainly seen that in the kind of heart failure cohort. And this is just to show you the relationship of self-reported sleepiness to sleep apnea severity. So you can see here that the Epworth Sleepiness Scale, which is frequently used in most sleep clinics to sort of delineate subjective sleepiness, a score of 10 or greater suggests you're sleepy. And as you can see, there is actually a number of patients with pretty bad sleep apnea, the 30, remember, is that cutoff of severe sleep apnea, who really don't report that, significant sleepiness symptoms. And there's also folks with very mild sleep apnea who, report significant sleepiness. So again, getting back to not necessarily a relationship between symptoms and severity, but certainly, again, there's a relationship between outcomes and severity. So this comes from the clinical guideline for the evaluation and management of obstructive sleep apnea. And I think, when patients come in with their sort of classic complaints and symptoms, severe snoring, wake up choking, gasping, feel tired during the day, fall asleep in traffic, we're pretty good at recognizing that those folks are, need further assessment and need evaluated. Things to keep in mind pertinent to the OSA kind of routine evaluation is, again, looking for obesity, looking for craniofacial abnormalities such as retrognathia. Does the patient snore? Do they have hypertension, or are they excessively sleepy? And if they do have sort of OSA symptoms, we typically want them to get to a sleep study. And, in our state, unfortunately, we just don't have that number. We don't have enough specialists that everyone can get referred to a sleep specialist or, one of the specialty clinics that deal with sleep for every single person who probably has this diagnosis. And so when you're looking at these patients, again, you can see in that first top left, two girls with pretty bad retrognathia. You can see the chin just sits back, pretty far below the mandible. And you can just envision how that's going to impact the posterior lingual space and lead to obstruction. Here on the right, you have torus palantini, which are bony outgrowths that can actually put the tongue in a poor position to protect against apnea and also push it back into the airway and actually cause obstruction. In children, we always look at the tonsils. That tonsillectomy is usually the first line treatment for sleep apnea in children, and children are particularly sensitive to sleep apnea. There's been a lot of studies, mostly by David Getzal, just seeing the cognitive developments really impacted in children with obstructive sleep apnea. And then looking at neck circumference in individuals greater than 17 inches does put you at risk for development of obstructive sleep apnea. But one group I think that we kind of forget and really needs to be considered are these high-risk patients, the very morbidly obese patients. I mentioned folks with arrhythmias and strokes, but again, congestive heart failure, folks with a refractory hypertension. In our pulmonary hypertension clinic, all of these patients get screened for obstructive sleep apnea. And I'll show you some data. We probably need to put advanced COPD on this list, as well. So just a question for you guys to sort of consider: which patient would be appropriate for portable sleep testing? So the first guy, 48, has diabetes, is overweight, and is sleepy. Next one is a 12-year-old with ADHD, kind of a normal BMI, normal bicarb, really not that sleepy. 56-year-old with alcohol abuse and dilated cardiomyopathy who is sleepy, and then a 45-year-old female, hypertension and diabetes, and a BMI of 50 and an elevated bicarb, and an Epworth of 15, who's also sleepy. And I think just for time's sake, I'll go through this. So, in kids, portable sleep apnea testing is not approved, actually. So all kids, per guidelines, currently need to come through the sleep center. The third patient down, the 56-year-old with cardiomyopathy, patients with cardiomyopathy are high risk for those more complex types of sleep apnea that really can only be diagnosed and treated in a sleep center because they use much more advanced sort of PAP modalities. And then this final patient, the 45-year-old female with hypertension and diabetes, is very obese and has an elevated bicarbonate. So she's at high risk for obesity hypoventilation syndrome. So again, that's where you actually retain CO2. So the recommendations would be she actually comes into the sleep center And we may do transcutaneous CO2 monitoring on her during the study, and actually try and ventilate her as well as treat the apnea, depending on how she responds to therapy. So actually the patient who would be most appropriate for portable sleep testing would be the first one, the 48-year-old male who's sleeping. So when we do a sleep study, what do we check? So this is sort of your classic in-lab sleep study. You have limited EEG, looking at sleep stages. You have chin EMG, looking for that paralysis you get during REM sleep. We have an EKG lead. As I mentioned, there's a very strong association between apnea occurrence and arrhythmias. We look at saturations. We also look at abdominal and thoracic effort by rip belts, which are little belts the patients wear. And that really looks at respiratory effort and helps us decide, is this a central apnea process or is this an obstructive process? And then we look at airflow, and usually with a nasal pressure transducer as well as a thermistor to look at decrements in airflow. And this is an epic of REM sleep where you can see in that ROC and LOC, those are your eye leads with the rapid eye movement. And again, you can see the EMG is completely flat because, you know, we're paralyzed in REM. And then the EEG showing this sort of mixed theta pattern. So what happens during, you know, a respiratory event? So these are recurrent hypopneas during the night. So in the flow signal, you can see there's a decrement in airflow. Below that, associated with hypoxemia or desaturation. And then you can see the arousals occurring intermittently, where the EEG actually speeds up there at the top. And you can imagine this is a 30-second epic, and this patient's just doing this recurrently throughout the night, every like 30 seconds a minute, just waking up, having recurrent hypoxemia throughout the night. So best practice approach. So home sleep testing. These tests are really reserved for folks with high pretest probability and quote unquote no significant cardiopulmonary comorbidities. You know, that kind of qualifying statements more from lack of data than you know, any harm or anything we might necessarily miss. That's based on ASM recommendations. I always tell people if someone's on supplemental oxygen, they probably need to come to the lab. If they have like some mild COPD or some well-compensated diastolic heart failure, it's probably fine to do a home sleep test on them. It's really going to be interesting with COVID because, you know, essentially all the sleep labs were shutting down and people were just doing the best they could and doing, you know, a lot of home sleep tests on these folks with significant comorbidities. So I'm kind of interested to see if some data will come out saying, you know, maybe we can consider these types of diagnostic tests in these patients. The full night attended is, you know, what I demonstrated to you. Again, patients with significant comorbidities, particularly those at risk for like complex apnea, hypoventilation syndromes, they really need to come into the lab. A lot of our older patients sometimes will struggle a little bit with getting the devices on. They've gotten simpler and simpler, and this isn't as big a problem as it historically had been. But you know, occasionally patients will go with a home sleep test and we'll struggle putting it on, or we won't get very good data, or it might even be negative. And again, home tests are for high pretest probability patients. So current recommendations is if you really suspect sleep apnea, you have a negative home study, you really should do an in-lab study. And then there's split night attended polysomnography, where we spend the first couple hours of the night sort of diagnosing sleep apnea, and then the next 4 to 5 hours getting folks on treatment. These tests are really reserved for patients who need diagnosed and identified quickly. I do think patients do better if they have like a full night titration study, because it really gives the tech time to work with them on different masks and, you know, titrate pressures and stuff. But like truck drivers can't go back to work until they're treated for obstructive sleep apnea. So that might be a cohort that we would, order a split night attended study on if they're coming into the lab. Some people just need requalified to get like a new machine and they do great with CPAP. That's another group we might bring in for a split night. But those are sort of the basic tests we do. So when we do a portable sleep test, what do we check? And it's really just a respiratory test. As you can see there, we look at airflow, respiratory effort, oxygen saturation, and pulse. And just like, our in-lab studies, we look at for these decrements in airflow associated with desaturations. And you can see here the respiratory effort, when they compensate, they start over breathing really hard and really increasing their sympathetic tone and putting pressure across their thoracic cage there. So when we do a home sleep test, what sort of information do we get? So this is a diagnostic report you may receive where, presumably a sleep medicine physician has gone through and looked at these different events and, scored them and gives you that AHI number again, which is the number of events you've had per hour. In the sleep lab, it's during sleep. With these, there's no EEG monitoring, so it's really based on recording time. So I would say these tend to underestimate apnea severity in a lot of patients. So we see in this patient that they had mostly obstructive events. Everybody has a little bit of central apnea, typically during sleep stage transition. So this is someone who, a primary care might order this test and say, hey, this patient has moderate obstructive sleep apnea. That may impact their health long term, so we should do something about it. And what we do a lot of times now is auto CPAP. So a patient might not even see the inside of a sleep center during their diagnosis and management of obstructive sleep apnea. And typically with an auto CPAP, we just set a range instead of setting a static pressure and kind of default. Almost all the time we do 5 to 20 centimeters of water pressure. And essentially the machine will watch patients breathe at night and will increase the pressure until it eliminates those apneic events. And as you can see, ideally, this patient will use the device, and you can see this patient is using the device very well, about 6-7 hours a night. What insurance looks at is this percent of days used greater than 4 hours. That's how they define adherence and will pay for the device. So it usually insurance will rent the device for 3 months. And then if this number is greater than 70%, they'll pay for the device, and it's the patient's. And then you want to make sure their apnea is well controlled. So this guy dropped from 16 to about 4. And less than 5 we consider, absolutely normal. So I would say, that patient, this is a good win, and hopefully they're feeling better and tolerating the CPAP well. Where does this come from? So, historically, all patients were managed in a sleep center. But there was a lot of issues with access, very long wait times and lines at sleep centers. So a number of groups kind of started doing this work. This is one, I believe it was from Philadelphia and Boston, and then a lot of work done at VA medical centers across the country as well, looking at these portable sleep tests. And essentially they randomized people to, doing the classic in-lab PSG, getting diagnosed with obstructive sleep apnea and getting treated, versus doing a home test where they looked at sort of folks with moderate sleep apnea, and then they started on one of these home auto-PAP devices. And as you can see here, sort of interestingly, the results were fairly equivocal. And actually in one of these early studies, it seemed like patients actually used their auto CPAPs better than the folks who went to the lab. I do not believe this has been replicated. It seems like it's essentially non-inferior. But across the different groups, sleepiness improved. This is the Epworth. Sleep quality also improved, functional outcomes of sleep questionnaire, and then healthcare quality of life actually improved in both groups. So it's, you know, portable sleep apnea or portable management of obstructive sleep apnea has really been looked at as non-inferior to sort of lab-based management. I put this slide in here. This just kind of goes over the different devices we use in obstructive sleep apnea. The majority of patients who are treated up front actually end up in on CPAP, or as I mentioned now, an auto CPAP. BiPAP you may see patients on. Really, in straightforward obstructive sleep apnea, BiPAP doesn't improve, you know, apnea control by any means. It's really more just for comfort. With BiPAP, you get a higher inspiratory pressure and a lower expiratory pressure. So it's more, I guess, physiologic. The way we breathe is a way to think about it. But they've actually randomized folks to CPAP up front versus BiPAP, and there's no difference in outcomes in apnea control or differences in adherence to therapy. Now, there are some unpublished work at this point, but there's certainly patients who fail CPAP therapy just due to difficulty breathing out against continuous pressure. You do fairly well with bi-level therapy. So if you ever have a patient who fails CPAP, BiPAP is a, you know, reasonable alternative to try. Then some of these more advanced devices we use more for complex apneas or complex respiratory disorders. But sleep apnea, you know, therapy isn't, CPAP therapy isn't effective for everybody. When you look at sort of national outcomes, about 50% of people will use their CPAP, love it, and not sleep another night without it. But that leaves another, like, and if you mess with their settings and their mask, you might get another 10-15% to use one of these devices. But that still leaves a good proportion of people who are like, there's no way I'm going to wear this thing. What else can we do? Some of the other things we can do are, you know, surgery such as UPPP. Kind of stiffens the palate. Sometimes you have very obvious, you know, obstructions like that picture of the tonsils I showed. You take those tonsils out, sleep apnea will resolve. Oral appliance therapy can be very effective, and there's, you know, good data, particularly in mild to moderate obstructive sleep apnea, can be very effective. And then upper airway pacing, which is, we just started a program at WVU. So this is actually an implantable pulse generator that attaches to leads in the on the attaches to the hypoglossal nerve, which stimulates the genioglossus and other pharyngeal dilator muscles to treat apnea. And there's a respiratory sensing lead. So as I mentioned, you get those big swings in thoracic pressure. This device notes that, knows you're having apnea, and it stimulates these muscles and treats apnea that way. It's very effective for, you know, moderate to severe disease. I believe WVU, Dr. Koutras is doing these implants for us. And I believe we're the only site in the state doing it currently. I'm actually going to skip this question for time. So how are we doing in West Virginia? So this was from our sleep center. And I will say, when we published this data, we were just sort of ramping up our portable sleep program. So this group one is patients who were managed completely on an ambulatory approach. So you can see, as we were ramping this up a few years ago, the numbers were a little down, but when you looked at adherence after, you know, 6 months of therapy, I believe, or 3 months of therapy, patients who went that ambulatory route, only 18% were adherent. If they came into the lab, they got a little better. We got them up to 32% adherence. But people who went through a complete lab-based titration actually did very well with therapy, which is sort of interesting. And, you know, why did our group do so poorly? Now, there are certainly some problems with this study. This was a small study. The group who came to the lab, you could say, are sort of more motivated to do treatment, but you know, this at least was kind of hypothesis generating, and then like this is a pretty dramatic difference, 18% versus 83%. So it got us thinking, you know, is there some unique barriers in our just local population with, you know, geographic isolation and all the other healthcare disparities that maybe this portable approach needs more fine-tuned for a rural population. And I should mention all those studies looking at, you know, ambulatory versus lab-based approaches were done in huge urban centers and VAs like, you know, Philadelphia, Boston, Toronto, Los Angeles, Chicago, which probably doesn't capture the types of populations we have in West Virginia. So why is this important for West Virginia? Well, I think number one, the obesity epidemic is hitting the U.S. everywhere, and no place has been hit harder than our state in Appalachia. And obesity is a big driver of obstructive sleep apnea, and we've even seen sort of on national data a big increase in the amount of sleep apnea, the prevalence of obstructive sleep apnea. And I'm sure it's even worse here. And this is 2016 data. And I just looked at the 2019 data, and we're just about at 40% now, which is for obesity rates in West Virginia, which is kind of unbelievable. And then as I'll show you data next, you know, sleep apnea really kind of can impact the trajectory of COPD and heart disease, particularly heart failure. And unfortunately for West Virginia, we're also leaders in COPD and heart disease, particularly severe COPD. So identifying sleep apnea could really impact the health of our local population. So this is a study, you know, one of my colleagues and our division chief, Sunil Sharma, published from patients who were admitted to the hospital for COPD in an inner city, actually. And they screened all these patients admitted for COPD exacerbations for obstructive sleep apnea. And when they followed them up, you could see the 30-day readmission more than doubled if you had sleep disordered breathing. So these were patients who were readmitted for a COPD exacerbation. It seemed like this was driven a lot by uncontrolled, untreated sleep apnea. And the more severe your sleep apnea was, the higher likelihood of your readmission. And this is a Kaplan-Meier curve, again, looking at death or readmission. And as we've seen with other data, particularly that moderate and severe group, those patients really had a poor survival probability or time to readmission. I mean, that was really dramatic. And there's been some retrospective work done on this in Spain. This is Jose Marin's group, looking at you know, COPD survival. And again, these were patients who they followed out, looking at survival and exacerbation-free survival. And again, this was a retrospective analysis. It wasn't prospective like Dr. Sharma's, but they looked back at people with COPD and OSA, this so-called overlap group. And patients who are treated with CPAP seem to do much better when they compared to the folks who weren't initiated on CPAP, both in survival as well as readmission rates. And this is a prospective study looking at incident heart failure and coronary disease, and particularly in men. You can see again the severe group were more likely to develop CHF based on it having severe disease. And this is a similar study that Dr. Sharma did. Again, he's our new division chief, looking at you know, heart failure admissions. And again, they looked at patients who were compliant versus non-compliant after they were diagnosed with obstructive sleep apnea, and looked at total number of clinical events. Again, this can be hospital admission, increasing diuresis. I think they included death as well. In patients who were effectively treated with sleep apnea, you saw a significant decrease in the number of clinical events after they were initiated on therapy. So we did a similar study. We published this 2 months ago now, just looking at, you know, all comers to our local at WVU, and a large number of patients who were screened positive for obstructive sleep apnea didn't do well with therapy previously. So some of these patients were actually screened and treated in the past and did not have success with therapy. And then we took them through an algorithm using portable sleep tests in our institution and didn't do a great job of, you know, diagnosing obstructive sleep apnea. We've kind of refined our protocol now, and we have a pretty robust hospital sleep medicine program. But even in the patients we identified, you know, we didn't do a good job of getting these folks effectively treated. So again, I think this gets back to just, you know, there's some barriers that I think are unmet in our rural population that makes this sort of portable management of or outpatient management of obstructive sleep apnea particularly challenging. And again, that's very important because of the amount of heart failure, COPD, and amount of obstructive sleep apnea we have in the state. So I think, you know, things to do is, you know, one thing we have to educate the public on the disease and just make people understand, you know, this really can impact your health, particularly if you have certain healthcare comorbidities. Educating primary care providers on the disease, and I've met with a number of FQHCs throughout the state. We're actually developing a project and getting ready to put a grant into NIH, looking at ways we can better sort of work with our primary care providers on this disease. And part of that's going to be improving our ambulatory management. Part of the answer, I think, is going to be telemedicine and telesleep, and thankfully I think COVID's hit the fast forward button on that. But with the amount of disease in our state and versus the number of sort of providers, I think the idea that specialists are going to be able to see every case is just not practical. I think hospital-based screening may help us identify some of the patients that go unrecognized, but also that's not going to be the complete answer. And then I think understanding and addressing some of the barriers and challenges in caring for our local population will be very important. And we're actually forming a focus group study at some different FQHCs to really understand, are there things on the provider side that are barriers to care for obstructive sleep apnea. So just in conclusion, it's a common condition, underdiagnosed both on a national level and locally. Just remember these high-risk patients. Today, most diagnosis and treatment is completed outside the sleep center, so being familiar with these tests and these auto-titrating machines, I think it's important. And then, again, just to reiterate, particularly important in our West Virginia population, because it can really impact some of the chronic respiratory and cardiac diseases we see in our communities. So, sorry if I went a little long there. Any questions?
Thank you so much, Dr. Stansbury. That was awesome. And Dr. Sharma actually has given us some didactics as well previously, so that's awesome. Any questions for Dr. Stansbury and his didactic? Feel free to unmute or chat as well.
See, Dr. Doyle's on there.
Dr. Doyle, it's very true. You chatted in. There are always questions. Got a few more folks on as well throughout the didactic, which is awesome. Maybe we could have them briefly introduce themselves to the group as well. So Krista Critchfield, did you want to introduce yourself to the group? I saw you hopped on a little after as well. Maybe muted. No worries. And Lisa Emery, I saw you hopped on as well. And Beth Hudson, I see you're in the car. No worries if you can't unmute to introduce yourself to the group, but we're glad you could join as well.
So Krista Critchfield is the respiratory therapist at Cabin Creek Health Center. Lisa Emery is at New River. I'm not sure if their mics don't work or they stepped away. So you guys, if you come back, speak up.
Hi, I'm Krista. Sorry, I had a provider in here for a second.
No worries at all. Thank you for joining.
I was talking on Zoom, Beth.
No questions today? Lisa
Emery, we got to get her a microphone. Maybe I'll put that on my to-do list today. Because that's, so I wanted to, well, first of all, I wanted to say, Rob, I can't wait for the pulmonary toxic drugs talk. That's a great project, and I'm looking forward to it. And Mithra explained why that didn't, well, apparently that was explained at the beginning, and I came late. So,
Yeah.
but I can't wait for it. Because that's so, that one's even more unappreciated by primary care providers than the one you just did, I think.
Mm-hmm.
And fits into the big polypharmacy problem. And we've got several of the Grace Ann Dorney sites and the APHP sites here today. Johnny's here, Aaron Erb, Lisa, Krista. And one of our 4 big goals is primary prevention of COPD. This is a great example of another area that we can work in prevention. I guess, let's see now. I'm not sure if it's secondary or tertiary. I think both. People already have disease, but we're preventing bad outcomes that you just demonstrated. So this is really an important opportunity for us as a network to be doing prevention as well as rehabilitation. And then I wanted to add, I have a terrible time, as a primary care provider, I have a terrible time making sense of sleep studies. And so I would really appreciate it if you would go back to that slide where you showed us the report.
Sure.
I think it was the one right, I took a picture of the slide that was the graphic of the home portable study, but I think 1 or 2 slides after that, you showed us the report.
Mm-hmm.
And I don't know about other people, but I really get dizzy and my eyes go blurry when I try to read these sleep study reports, lab or home. But home is more important because frequently those are not interpreted for us, and it's up to us to interpret them. Yeah, this is it. Yeah, that's it. I'm gonna put it to the full screen for myself. Try to here. Okay, so when I look at your guideline of AHI greater than 30 is really bad, and 15 to 29 is pretty bad. That I can hang on to that and probably remember that.
Mm-hmm.
But when I look at this on that events index, both on the y-axis and the x-axis here, I had a question. So going across, what's the 9.7 and the 6? Are those ranges normal or?
So it's the apnea index and the hypopnea index. So, those are different respiratory events we score. So apnea is a decrease in airflow by 90%, and hypopnea is a decrease in airflow by 30% that's associated with the desaturation.
So these two are additive then. They're summing in that first column.
Yep.
Okay. All right. But if sort of barely literate primary care providers like me hang their hat on one thing, it's that AHI.
It's that AHI, yep.
Okay, and then what about in this study that was a home study, or was this a lab study?
This is a home portable study, yep.
So where are we getting these supine, non-supine, and upright measures?
So there's sensors on the rib belts that kind of sense when someone's on their back versus on their side. This is sort of new technology. It's fairly well validated, actually. I didn't go into this, but you could see in this patient that actually their apnea is much worse in the supine position. So when they're laying on their back, So you could make the argument in this case that positional therapy would help them. That would either be kind of propping them up with a wedge. I've had patients who actually sew a tennis ball in the back of their t-shirt, so when they roll over, it kind of irritates them and they roll back on their side. I didn't get into that, but supine apnea is based on apnea being worse in the or twice as bad in the supine position versus the non-supine.
Okay, and then the morbidity associated with sleep apnea is completely driven or primarily driven by oxygen desaturation? Because I want to go down and look at those sat lines down there.
Yeah, so no, it's oxygen saturation's a part of it, but remember, these folks have a big increase in their sympathetic tone, and then the big swings in thoracic pressure that accompany these respiratory events. So it's multimodal, or it's sort of multi-hit, and I think that's an important point, because one question I get asked all the time is, well, if they're not using CPAP, does just treating with oxygen make a difference? And the answer is probably no. I don't have great studies to support that, other than some animal models and some kind of retrospective stuff. But you know, when you think about the basic pathophysiology of sleep apnea and the consequences, you know, just supplemental oxygen's only hitting a kind of 1 out of 3 parts of the equation.
So on those 3 lines there, we got oxygen desaturation, and then I think another problem for me in looking at the sleep studies is all the abbreviations that I don't know, and sometimes don't have the fine print at the bottom is too small for me to find what they stand for. But what's ODI?
Oxygen desaturation index.
So does that mean that this person was desat? So what does that one mean?
So that's the number of 4% desaturations the patient had per hour. Now it's sort of interesting. You can see the ODI almost correlates with the AHI, correct? You guys see that?
Yeah.
So we're actually using, what we've started using for our hospital-based screening is high-resolution pulse oximetry as a surrogate for AHI to you know, screen people for obstructive sleep apnea. The problem with regular pulse ox in screening for obstructive sleep apnea is the kind of time frame that it analyzes data. It does it in 30-second increments. So you actually miss a lot of desaturations. It kind of takes the mean of like 30 seconds of data and reports it. Where the sampling time for high resolution pulse oximetry is like every 2 or 3 seconds. So, and that's what most of the sleep devices use. And again, that's what we're using in our hospital for screening for sleep apnea, is high resolution pulse oximetry. And, you know, Dr. Sharma has actually done a lot of work in this, and it correlates pretty well using high resolution pulse oximetry and ODI, looking at your apnea and correlating that with your AHI.
That answers all my questions. And then as you were talking, I just figured out what the red wedge represents at the top. It doesn't actually correlate with these columns, the text columns below. It's more just a spectrum, and you've marked where this person is on the spectrum, I think.
Yeah. Dan, I wish I would have included you guys at Cabin Creek for my focus groups, because, you know, what I'm really trying to tease out is, you know, would some sort of education be beneficial for primary care providers at our FQHC sites. So that's one of the reasons I'm doing the focus groups, and hoping to use that data I garner from the focus groups to get, you know, an NIH grant supporting that intervention. So.
Yeah, and Grace Ann, if you're still there, you know, this is such a parallel. You know, there's such a parallel here between our efforts to educate primary care providers about the importance of pulmonary rehab and Dr. Stansbury trying to educate primary care providers about the importance of screening and intervention here.
And you know, one thing I think that's such an issue, and Dan, maybe you could shed some light on this. And you know, one of my mentors on this project is Judith Feinberg, who has done a lot of work in hepatitis C and primary care, identifying it and even managing Hep C. But yeah, and you know, the primary care folks in our state are the most important doctors, you know, in the entire state. But it just seems they're so overwhelmed with, you know, I got to manage the diabetes, the hypertension, the COPD, you know, yada, yada, yada. And, you know, I think one thing that I'm going to struggle with is, you know, adding one more thing to the pot for them to think about. But, you know, I don't know what your thoughts are on that.
My thought is that it deserves a lot more thought.
Okay. Yeah, well, that's good to know.
We just got a chat in from Aaron Erb as well, saying that they just did office visits to their primary care physician offices to talk to them about pulmonary rehab and the importance of it. And no worries, we totally get that the audio got disconnected. So thank you for chatting that in, Aaron. Other comments or questions? We have about 2 minutes left.
I have a question. I think the biggest thing with sleep apnea is the obesity, and how determined are you to get these people to lose weight with this problem? And
Yeah,
as far as diet, drug, I mean, I know my facility is FQHC. I work out in Whitesville, West Virginia, and we can't prescribe diet pills because our insurance doesn't cover them. But these people will not lose weight. You know, I tell people to lose weight and they gain weight because I told them to lose weight. So I'm looking at how to motivate these people to lose weight because they don't understand the mortality of this disease.
Yeah, you know, we're blessed. We have both a medical weight loss clinic as well as a surgical weight loss clinic. So I use, you know, bariatric surgery quite frequently in our patient population. You know, across the board, you should always talk about fitness and weight loss with your sleep apnea patients. And like I said, I make a lot of referrals, and the ATS just put out a statement on, you know, things to consider when sort of counseling your patients with sleep apnea on weight loss. You know, my experience has been unless you can take like 30 minutes to do it, it's not effective, you know, and you know, a lot of clinics, it's just hard to do. So that's why, you know, I refer most of my patients to either our surgical weight loss center or a medical weight loss center. I just feel like they have much more success doing that. That's always
success in those patients.
Well, so if you look at sort of the bariatric data, you know, about 75% of patients who undergo bariatric surgery, their sleep apnea will resolve. So there is still about a quarter of patients who, despite losing weight, will still need some sort of therapy for their sleep apnea. Now, the modality a lot of times will change. Like say, you know, when they're very obese, their CPAP might be at 20 and they might be really struggling to use it with such a high pressure. They go through bariatric surgery and lose 150 pounds. Now their CPAP's at 8 and they may do quite well after that. Sometimes we can even switch to something that's more tolerable, like an oral appliance therapy. That you know, one of our dental colleagues will fit someone for. Yeah. Now, getting people through the bariatric process is very challenging. historically, the Medicaid population, it was almost impossible to get them approved for bariatric surgery. From what I understand, they've lessened the requirements for that now, and they're paying for it because they finally understood. I mean, you know, weight loss helps sleep apnea for sure, but you know, the other health consequences of obesity, diabetes, heart disease, everything else gets a lot better too. So, you know, there's more reason to talk about weight loss than just the sleep apnea part.
And you know, the bariatric surgery, I have not seen much success. I mean, they lose weight for a while, but they gain it right back. So I'm not a big push for bariatric surgery, just because of the risk of the surgery for one, and the complication risk, and they gain it back because they don't stay on the, you know, the discipline of learning how to eat right. You know, I think that's the biggest thing. I mean, there's you looked at the studies on how many patients actually gain their weight back after surgery.
Yeah, I was just going to say, I mean, one that comes to mind was one where they looked at, it was about 5 years out, and I think 60% of patients were back to their pre-intervention weight. So your point is definitely well taken. I think some of it depends on what surgery they use. So like the banding, stuff like that, that it seems to be less effective long term, but you know, it's a much more minimally invasive procedure with less complications. When you do the kind of full Roux-en-Y, that probably has more effective long-term outcomes because you almost have to limit your diet. But obviously with the complete bypass, there's more complications associated with that. So.
Thank you all so much. We have come to the end of this session hour. Dr. Stansberry, I want to thank you again for being able to join us today and give that awesome didactic. And hopefully sometime in 2021, we can have the pulmonary toxic drug didactic. I know Dr. Doyle really was looking forward to that as well. So
yeah, sorry guys, I've missed being involved, but you know, with the new fellowship, we're doing our didactics on Mondays right now. But hopefully in 2021, I can get back because I really miss participating in the ECHO. So.
Absolutely, that would be wonderful. Thank you.
Take care.
So a couple housekeeping announcements before we part ways. Our next session will be on November 16th, and Dr. Doyle is providing the didactic on home-based pulmonary rehab. So keep an eye out for that email reminder. And thank you all so much for joining. We'll see you guys next time.